everyone, my name is Hannah Hayden, and my topic is treatment for sex offenders, both male and female. This will cover a sliver of Chapter 15, Correctional Programming and Treatment. In this presentation, I will be going over different topics that are most commonly talked about when discussing treatment for sex offenders. Introduction. I will be going over the different types of sex offenders, the rates of reconvicted sex offenders, the polygraph testing and penile plethysmograph treatment, the chemical castration treatment, male sex offenders versus female sex offenders and how they are differently researched, and the most commonly used treatments these days. Then I'll have my conclusion, my discussion question, my feedback question, and all of my sources used. Types of sex offenders. There are many different types of sex offenders out in our communities. When thinking of sex offenders, we tend to think of someone who is older and is looking at younger kids in the wrong way. But sometimes something as simple as urinating in public can land you on the sex offender registry. I learned in research the different tiers of being a sex offender. You have 3 different tiers because there are multiple things someone can do to become a sex offender. In the first tier of sex offenders, you have public nudity, a person who has or receives child pornography. You also have someone who falsely imprisoned a minor, and a person who takes videos of minors. The list could go on, but that gives you an idea for Tier 1. In Tier 2, you have someone using minors in prostitution and or sex trafficking. You also have someone engaging in a non-forced sexual act with a minor aged 16 to 17. And lastly, using minors in a sexual performance. From Tier 1 to Tier 2, you can already see the major difference in how much the sex offenders escalated with minors. Then, when you look at Tier 3, and these are the most commonly known sex offenders, you have a non-parent kidnapping a minor, someone having sexual contact with minors under the age of 13. Next, you have someone sexually abusing a minor. Every tier is different, and every crime in every tier is different. So how do you create a treatment for these sex offenders when everyone has done a different crime? How is the treatment the same for someone who urinates in the park and for someone who had sexual intercourse or abused a minor? Rates of reconvicted sex offenders. To start off, when looking at sex offenders, treated or non-treated, the percentage of them being arrested again for committing the same or a similar crime is 5%. But based on the average of 46 months that a person is back into the community, you are looking more towards a 12.3% of sex offenders who have been treated being arrested again. These criminals were worked on and released back into the community but still ended up going down the same path. So after 46 months out, a sex offender who was not treated while in prison had a 16.8% chance of being arrested again. A man named R. Carl Hansen did studies of sex offenders who commit a new sex offense crime with his colleagues. In 1998, after looking at 61 peer-reviewed articles and 23,393 sex offenders, he learned that 13.4% of those sex offenders did a new sex crime after being released. In 2005, he read 82 peer-reviewed articles and studied 19,267 sex offenders. He learned that 13.7% of them committed another sex crime. Even after 7 years, the percentage was very similar. It even went up, which is not good for the communities. One of the things the U.S. has created to help identify sex offenders is the penile plethysmograph. It is similar to a polygraph test. Polygraph testing and the penile plethysmograph. Polygraph testing has been around for years. It's a lie detector test. We see them all the time being used against criminals. But as we all know, sex offenders are very good at lying, and when they used to use it, they would lie their way back into the community and recommit their crimes. But now there is a new type of polygraph testing called the penile plethysmograph. And what it does is it measures blood flow in the penis. It looks at the level of swelling of the penis when exposed to deviant sexual images. They show pictures and videos of adult sexual images to get a base read, then show photos of, let's say, this certain sex offender liked young boys. They would show a photo of a young boy and measure the erection. In our textbook, it says a man achieves a 10% erection viewing non-deviant heterosexual pornography, but achieves a 75% erection when viewing sex involving young boys. This testing has provided a way for psychiatrists to track and follow along the journey of treating sex offenders, and it helps prove to the sex offenders that they truly are attracted to their type. Sex offenders often never console or understand that what they think about these younger kids is truly disturbing and not okay. So when they physically are being tested, it opens their eyes to the true disturbance they have done and helps them get on the right track of bettering themselves. The penile plethysmograph has a 92% accuracy and is now the most common identifying method of sex offenders in the U.S. A treatment that is most commonly used is the chemical castration. The chemical castration is only used on male sex offenders. It is a biomedical treatment for sex offenders who have constantly recommitted the same or similar crimes. A synthetic hormone called Depo-Provera is put inside the sex offender. Depo-Provera is supposed to reduce the sexual thoughts, fantasies, and erections of a person by changing the level of testosterone in the body. This is a great treatment for those sex offenders who aren't changing and they just need help to change their ways. Since chemical castration is a drug, it's what they call irreversible. So once the sex offender starts this treatment, it can't be stopped because if you stop it, it stops all of their emotions. If you stop doing it, all of their emotions would come back to them about being with little kids. The graph I have provided is the U.S. male treatment rates from 1990 to 2016. It is showing how effective Depo-Provera is and if it's lowering the amount of recommitted male sex offenders. Male versus female offenders. Male sex offenders have a lot more treatment and research done on them than female sex offenders. Rosuo and Cartoni are two men who did research study on female sex offenders that did not end very well, made a very strong claim saying that mostly all female offenders suffer from some form of psychopathology, while men sex offenders aren't looked at so wrong in the head. Male sex offenders are looked at as creeps and known as dogs, but when there is a female sex offender, it is the worst of the worst. Female sex offenders aren't as common as male sex offenders, making the research done on them very unreliable and small. This meant there couldn't be a treatment like chemical castration because there simply wasn't enough female sex offenders who recommitted the same crime. Most female sex offenders learned the first time. Female sex offenders are less likely to recommit the same crime than male sex offenders, which is why male sex offenders are a lot more dangerous than female sex offenders. It is proven that if a male and female sex offender did the same act to a child, the child would be less affected by the sexual act if it was done by the female. 521 parents who had experienced sexual abuse when they were young got asked whether male sex offenders or female sex offenders were more abusive, and majority was females were less abusive than the male sex offenders. The table I have on this slide is showing the number of male and female sex offenders in prison. It is showing how there are significantly lower numbers of female sex offenders. Treatments. Treatment of sexual offenders has evolved substantially over the years. Various theoretical and practice models of treatment have been developed, modified, refined, and proposed over time. The current recommended approaches, supported by research, adheres to specific principles of effective correctional intervention, follows a cognitive behavioral skill-based orientation, and explicitly targets risk factors associated with sexual offending and with recommitting, such that risk of reoffending may be reduced. Cognitive behavioral treatment focuses on changing behavior, cognition, and affect, using a skill-based approach with the aim of reducing risk of reoffending the same crimes. The focus of the treatment is on alternation patterns of behavioral, cognitive, and affective responding associated with sexual offending. They try to change the attitudes and challenge the cognitive distortions by forcing them to create a new environment accepting what they have done. At the beginning, when they first started treating sex offenders, they looked at the conditions of their behavior, but sex offenders would tell themselves that they were fine, but in reality they were not okay. Then later, they started to go to more therapy and trying to figure out how to help the brain be aware of what is happening. Prisons have started adding more therapists to help consult sex offenders and figure out if anything happened in their life to cause them pain. Prisons are also trying to help sex offenders feel safe and that they have someone to talk to because it is hard to relapse, and after someone uses, say, the chemical castration, going out into public would be very hard on them. Prisons are trying to help sex offenders get back on their feet, but in reality these inmates are sex offenders and can't be trusted, so they are being forced to stay longer in prison. In some cases, most sex offenders will go back to prison because they didn't register themselves as sex offenders or didn't alarm their neighbors and neighborhood of their past. Having a sex offender living next to you or even near you can be scary because most are mentally ill, so when a sex offender doesn't register themselves as a sex offender, they go back to jail and get even more treatment with a therapist. This is my conclusion. In the end, the treatment for sex offenders keeps growing and becoming more honest and fast working. It is showing the truth about sex offenders and trying to create a way to help sex offenders move on with their life. Female sex offenders will continue to not have as much information on them, and the treatment will still be very basic because we just literally don't have the information needed to fully have an entire treatment for just female sex offenders. My discussion question is, knowing that male sex offenders are more than likely to commit another sex crime, what would you change or add to the treatments already provided to the inmates? My feedback question is, I would like to hear about if you thought my presentation was well organized and easy to follow. Here are my sources, and thank you.